This
interface.
conference will now be recorded.
Use of gain in difficult situation. Gain refers to electronic amplification of the sound waves received by the transducer. Increase in gain is required when height of echoes achieved is inadequate, as in dense cataracts. Decrease in gain is required when artifacts are seen near the retinal echoes, as in silicon-filled eyes, pseudophakic eyes. Immersion advantage. It is more accurate than contact method, as the corneal compression is avoided. The limitations is that it does not give accurate readings in silicon-filled eyes of posterior cephaloma. Immersion advantage. It is more accurate than contact method, as the corneal compression is avoided. The limitations is that it does not give accurate readings in silicon-filled eyes posterior cephaloma. The principle of IOL master. It is based on partial coherence interferometry. 780 nanometer measures echo delay and intensity of infrared light reflected back from the tissue interfaces, cornea and RPE. Principle of LENSTAR. Based on low coherence optical reflectometry, it uses the superluminescent diode laser of 820 nanometer. Principle of IOL Master 700. It is based on swept source OCT technology. It provides an image-based measurement, allowing to view the complete longitudinal section of the eyeball. So, what are the advantages of LENSTAR over IOL Master? The advantage of IOL Master is that in LENSTAR it measures the AC from LENSTAR it measures the AC posterior surface of cornea, which is important in chambers and thicker corneas. It takes 2 sets of readings, so covers more central area. It is also helpful for pachymetry, pupillometry, and retinal thickness measurement. And the next one is advantages of IOL Master 700 over LENSTAR. In PSC cataracts, opacity are located near to nodal point of the lens, so more light rays are affected, and thus excellent measurement becomes difficult with LENSTAR. IOL Master 700 overcomes this problem. Unusual eye geometrics like tilt or decentration of lens can be detected. Now, discussing about the IOL formula. We all know about the IOL formula. We have first generation, second generation, third, and fourth generation IOL calculating formulas. But fourth generation formula are superior to the earlier formula. These are a merger of linear regression methods with the theoretical eye models. They predict better effective lens position. Haigis uses multiple A constants like A0, A1, A2. Polari uses multiple parameters, including lens thickness measured by LENSTAR. IOL formula depending on axial length. For different circumstances, different choice of formula is used. For axial length less than 20 mm, Polari 2 or Hofer-Q is used. For axial length 20 to 22 mm, Hofer-Q is used. For axial length of 22 to 24.5 mm, SRT or Polari formula can be used. Similarly, for axial length can be used. 4.6 mm formula can be used. And for axial length of greater than 26 mm, we can use SRK/T formula or Polari 1 formula. For myopic refractive surgery, Haigis L formula can be used. For nanophthalmos, Hofer-Q or Haigis formula can be used. Similarly, for post-refractive surgery, topography with true net K and flattest K with formula according to the axial length. So, discussing on the main topic, biometry in specific situations. Aphakic eyes. We all know that two lens spikes are replaced by a single spike in between the anterior vitreous space posterior lens capsule. For aphakic eyes, immersion technique is the method of choice. In present biometers, options are available for aphakic mode, wherein the calculation compensates for change speed of the sound waves in cataract lens or aqueous or vitreous. In ACIOL or scleral fixated IOL, appropriate ACON stent is used. Keratoconus eye. IOL for calculation in keratoconus eye is very difficult. As cornea is steep, using key reading of such eyes will yield an overestimated reading due to effective position calculation error. For most which consider only axial length and not keratometry to calculate effective lens position with better prediction of true IOL power. Key reading has less of this effect in the Hoppertune formula. Also, overestimation is not a fact with the formula. Does not use. Also, overestimation is not a fact with reading estimating number. Biometry in toric IOL. Toric lenses correct the corneal astigmatism. Patients with rare astigmatism, otherwise having good vision potential and without any coexisting ocular pathogens indicated, requires accurate keratometry and consideration for surgically induced astigmatism, which depends on the size of incision. Like for accretion of IOL, the size of incision is 2.2 mm and surgically induced astigmatism is 0.2, 0.3 for temporal incision and 0.4 diopter for the superior incision. So for toric IOL, commonly used calculator for toric IOL power are calculator and the Holari IOL consultant software. Also calculator competes IOL based on target post-operative refraction. The new parameter of corneal astigmatism can be employed to include an accurate measure of corneal astigmatism with inclusion of the posterior cornea. Next one is the Holari IOL consultant software. It uses the forward planner and the backward planner technique. In the toric pre-operative forward planner, it is used to determine the ideal toricity and axis of placement for toric IOL, using reading and expected surgically induced astigmatism from cataract incision. The post-operative back calculator allows surgeon to determine the exact amount that the toric IOL should be rotated to produce the smallest residual astigmatism. IOL power calculation in eyes with silicone oil. Eyes with silicone filled vitreous or vitrectomized eyes. The refractive index of the oil is much less of the velocity and keep an error of 8 mm. Difficulty of measuring the exact can be overcome the system. Error in excellent measurement occurs as ultrasound travels more in silicone oil compared to vitreous, and thus taking a longer time to reach the probe, which is interpreted as longer wavelength. Usually a factor of 0.72 gives a rough estimate of the power. That is, true axial length equals to 1133 divided by 1550. The 1 into apparent axial length, 1133 is the velocity of sound in phakic silicone oil, and 1550 is the velocity of the sound in the cataractous eye. So the ratio gives a factor 0.72 and it is used to calculate the true axial length. As silicone oil alters the optics of the eye due to its refractive index, further adjustment in IOL power are required. However, it is less affected in optical biometry. Usually, IOL required is 2 to 3 times stronger than indicated by standard power calculation. Now, IOL power calculation in high myopic eyes. Accurate axial measurement is critical for IOL power calculation. Paraxial measurement in ultrasonic measurement due to post-staphyloma is likely to give a refractive surprise. It is partly overcome by optical biometer using a fixation target. Most of it is taken care in IOL Master 700 by directly visualizing fovea and the OCT image during measurement. IOL formula needs to be chosen accordingly. Minus IOL powers have to be chosen carefully by reducing amount of minus power. The surgeon should aim for a minus 0.5 diopter to minus 1 diopter post-operative refraction, as most elderly being nearsighted. IOL power calculation in pediatric eyes. As myopia increases rapidly in pediatric age group, goals should be undercorrection. Undercorrection of 60 to 75% is recommended depending upon the child's age. Younger the age, more is the undercorrection. Simple rule of thumb can be used in which target refraction equals to 7 minus age in years. A greater undercorrection can lead to anisometropia and difficulty in amblyopia correction. At times, managing amblyopia is more difficult than future IOL exchange. Therefore, undercorrection has to be done with care, especially in unilateral cataracts, unilateral cases. Like if we unilateral cataract since birth, then the cataracts will be extracted before 6 weeks of age, and then for less than 2 years, the child should be prescribed spectacles or contact lenses, and after 2 years only, the PCIOL can be implanted. So choice of lenses and dioptric power in pediatric in children less than 2 years, so undercorrecting biometry by 20% or by predicting IOL by using excellent can be done. Like 22 diopter can be used for the excellent of 21 mm, 24 diopter for 20 mm excellent, 26 diopter for 19 mm excellent, 27 diopter for 18 mm excellent, and 28 diopter for 17 mm excellent. Similarly, in children 2 to 8 years, undercorrecting biometry by 10% should be done. And greater than 8 years, same IOL power same as adults can be implanted. Pseudophakic eyes, IOL power calculation in pseudophakic eyes. We all know that in pseudophakic eye, extremely high spikes at the lens is followed by artificial chain of replication of echoes, which can be misinterpreted as spikes from the retina. It can be avoided by lowering the gain, which eliminates the artificial spikes and increases the retinal spikes. Sound speed depends on center thickness of IOL and sound transmission characteristic. Polari formula is developed for pseudophakic biometry, in which true axial length equals to 0.988 into apparent axial length plus thickness of the lens 1 minus 1532 by velocity of the particular IOL. So this is the formula to calculate for the pseudophakic eye, pseudophakic biometry. Next one is the piggyback IOL. An eye with short axial length will require stronger IOL. As IOL powers become too high, however, the lens become too spheric and image quality decreases. Using two lenses to obtain a needed high power correction results in an optically superior image compared with that obtainable by single lens of required power. So it is very helpful in short or nanophthalmic eyes. Piggyback minus lenses have been used in eyes of long axial length alone or combined with high corneal curvature to achieve minus powers commercially available in the single lens. Primary piggyback IOL. In primary piggyback IOL, Higgins or Hofer formula can be used. Ideally, one acrylic and one silicon IOL to avoid interlenticular opacification. Usually, a single piece in the bag and 3 pieces in the sulcus is placed, and power between the IOL is divided and one diopter is reduced for sulcus placed IOL. Secondary piggyback IOL for pseudophakia. Patients with residual refractive error following the primary IOL implantation is greatly benefited by the secondary piggyback IOL. It is calculated based on the refractive error, and Holadi's refractive formula is used. No knowledge of primary implant or the axial length is required. Raynaud's Salcoflex IOL power is calculated by giving the residual refraction while ordering. So for residual hyperopia, if the axial length is less than 22 mm, then IOL power 1.5 into spherical equivalent plus 1 can be used. And for axial length of 22 to 25 mm, IOL power of 1.4 into spherical equivalent plus 1 is used, and for excellent of greater than 25 millimeter, IOL power of 1.3 into spherical equivalent plus 1 is used. Similarly, for the residual myoper, for excellent of less than 22 millimeter, IOL power of 1.5 into spherical equivalent minus 1 is used, and for excellent of 22 to 25 millimeter, IOL power of 1.4 into spherical equivalent minus 1 is used, and for excellent of greater than 25 millimeter, 1.3 into spherical equivalent minus 1 is used. Now, IOL power calculation in corneal refractive surgery. Common keratorefractive surgeries which pose a challenge for cataract surgery are myopic LASIK, myopic PRK, myopic radial keratotomy with or without astigmatic keratotomy, hyperopic LASIK and hyperopic PRK. Keratometric error in radial keratotomy. Radial keratotomy flattens both the anterior and posterior corneal surface, but only in a small central optical zone. The effective optical zone diameter can be significantly smaller than the measurement zone of standard keratometry. Therefore, standard keratometry tends to overestimate the true corneal power. Furthermore, there can be central flattening after cataract surgery due to corneal edema. Most of the flattening effect resolves over several months. Sources of error in post-refractive cases, LASIK or PRK. The sources of error are the radius measurement error or keratometer error, or keratometry index error, formula algorithm error that arises from different formula, because most of the formula are dependent on the axial length and K reading. These three errors causes hyperopic error in myopic LASIK, error in hyperopic LASIK. So there are different methods of estimating true post-operative corneal power. It may be direct methods or indirect method. So first one is clinical history method. Here we need to first find the pre-operative K reading and also the pre-operative spherical equivalent. After that, the post-operative K reading can be obtained by the formula pre-operative K reading minus pre-operative spherical equivalent minus post-operative spherical equivalent. The next method is the contact lens method. Here in this method, first the spherical equivalent is noted both with contact lens and without contact lens, and if the spherical equivalent with and without contact lens is found to be the same, then the key reading of the cornea is same as the base curve of the contact lens. If myopic shift is obtained in refraction, then it is sure that the base curve of the contact lens is greater than that of the cornea by the same amount of the shift. Similarly, if there is a hyperopic shift in refraction, then the base curve of the contact lens is less than that of the cornea by the same amount of the shift. So the post-operative K reading can be obtained by the formula base curve of the contact lens plus power of the contact lens plus spherical equivalent with contact lens minus spherical equivalent without contact lens. The next method is corneal topography or keratometry method. It is the direct method. After LASIK, there is a 1 diopter overestimation for a change of 7 diopter and a 2 diopter overestimation for a change of 14 diopter. For example, if there is 7 diopter change in refraction at the corneal plane with a preoperative K equals to 44 diopter, the actual power of the cornea is 37 diopter, but the topography or keratometer reads 38 diopter. Therefore, whatever the change in post-operative K reading, undercorrect it by 14% to get an accurate post-operative K reading. If uncorrected, then there will be hyperopic error due to underestimation of IOL power. IOL power calculation in patients with corneal transplant. It is suggested that K reading of other eye be used. If there is a corneal scar but no graft is planned, other eye reading can be used, or even the power calculated using axial length and refractive error of the affected eye can be used. So this is the format in which the data is entered, like pre-LASIK or PRK data is entered above, and post-LASIK or PRK data is entered below, and also the optical IOL master lens star data values are entered here, and finally the IOL power is obtained. Choice of IOL. IOL with negative spherical aberration like Technics or Acrisoft IQ would correct spherical aberration induced by myopic glasses. Refractive multifocal IOLs further reduce contrast sensitivity and so not recommended. Diffractive multifocal IOL is not preferred as diffractive ring adds to already multifocal cornea and so not recommended. Following arcade over lack of precision of IOL power calculations, a diurnal fluctuation in refractive power and increase in spherical aberration precludes the use of refractive and diffractive multifocal IOL. There is a rule called the rule of 2S. In spite of the best efforts, if the final refractive objective remains elusive, plans for an IOL exchange or a secondary piggyback IOL should not be made until at least 2 months have passed and 2 refractions are stable at 2 consecutive visits. So concluding, while calculating IOL power, always take care to select the correct mode or velocity. Data input should be done very carefully. Always check and compare the axial length of both eyes to minimize errors. Recheck the pre-operative measurements under following circumstances. If the axial length is less than 22 mm or axial length is greater than 25 mm, average corneal power less than 40 diopter or greater than 47 diopter, the difference in corneal power greater than 1 diopter, axial length greater than 0.50 mm, and emmetropic implant power is greater than 1 diopter between the two eyes. IOL power chosen should be compatible with the history. Always choose a power that is suitable for patient age, profession, and needs. Surgeon factors should always be estimated, and optimization of IOL should also be done. Thank you. So, any questions?
Didi, it was a nice presentation, but it was, I think, I felt it too quicker. So, if our participants have queries, you can ask our presenter or note it down on the chat box, or directly you can ask by unmuting yourself. I can see our respected faculty member Gauri sir is among us. So I hope you will add some comments or
Hello, sir.
give some if he is
Hello,
available
sir.
with us.
Hello.
Good afternoon, sir.
Yes. Yeah, good afternoon. So it was a very brief and detailed descriptions you have given.
Thank you so much, sir.
Yeah, it's very much detailed actually. But because I'm out of the practice nowadays, so
Yes, sir.
I must say sorry. I could not comprehend all of the informations because I'm out of the practice nowadays.
Yes, sir.
But yeah, few of the genuine concern I have was like you said about the considering the contralateral eye for the intraocular pressure IOL measurement in case there is any sort of defect in the cornea or dense cataract or some sort of opacities. So,
Yes, sir.
is there any evidence that that suggests taking contralateral measurement is equivalent to measuring in same eye or ipsilateral eye? Do you have any literature
Yes.
regarding that?
Yes, so most of the literatures have claimed that like 0.5 diopter to 1 diopter, in most of the cases, the IOL power between the two eyes is same, and if it differs, then it only differs by 0.5 diopter or 1 diopter. So it is better to use both eyes, but in case of the silicon filled eyes, I think it is not better to use because the IOL power differs by a value of about 3 diopter in that case. So in silicon field eyes, I think the IOL power should be measured before performing the surgery.
And there is any study that shows the agreement between the topographic measurement and keratometric measurement of the uh, ocular dimensions that represent the IOL measurement?
Yes, sir. Some of the study have shown that with the topography measurement, it is the IOL power calculation is better with those formula, especially using the Hague's formula. It is better, but now still the research is going on, sir.
Is going in our center or the other place?
No, sir. In our center, we do not use Hague's formula, Olson formula. We only use Holade-2 formula of the fourth
Okay.
generation, and from third generation, we use SRK/T Holade-1 formula, sir.
Okay. Okay, thanks for the
But
answer.
still,
Yeah.
thank you,
Okay,
sir.
yeah, please continue. Please continue.
So, any other queries? I can. Hello.
Yeah, Manish.
Yes, sir.
Actually, I could not join at the earlier due to the electricity issues here. I just joined late. So I think that
Yes, sir.
discussed. So basically, the center fourth generation formula, or what we use in our center nowadays.
Sorry that I could not hear clearly. Your voice is very disturbed. Hello.
So which formula do we
Hello.
now use in our center for calculating the IOL power?
So I have already mentioned that for different axial length we choose the different formula, and we also compare both the formula in both IOL master and also the biometry. For axial length less than 22 millimeter, we often use OverQ formula. For axial length of 22 to 24.5, we use SRK/T and Olade formula, and for greater than 26, we use SRK/T formula.
Okay. So as we taken or see some considerations like residual refractive error after performing the refractive surgery, we performed the biometry.
No,
Have you seen pattern of
we haven't. Secondary IOL implant is very rare, and we have not performed. I think it is very rarely performed. In our center, I haven't performed yet.
Yeah, I think we should see this residual refractive error after performing a biometry. So sometimes what happens is that SRK/T formula is sometimes good for that type of wavelength. There is certain considerations like that. So I think from now
Yes,
onwards we have to check which formula to accurately place. Do we customize the formula, or we use a constant formula for calculating the IOL now?
We customize the formula
Customize one on the basis of axial length. We decide what.
Yes, we on the basis of axial length we determine the formula.
Okay, so in hyperopic eyes, what we use?
OverQ formula is used in high hyperopic eyes, and piggyback IOL is also it is also said that piggyback IOL is very helpful for the hyperopic eyes, very high hyperopic eyes, and Hague's formula is also better for the hyperopic eyes because it does not depend on only on the K reading, and but it depends on the AC depth and the lens thickness.
त्यही त त्यो फर्मुला चाहिँ हामीले अहिले कस्टमाइज गरी युज गर्छौँ. खालि पहिला त सायद SRK/T भनेर युज गर्थ्यो. अहिले चाहिँ डिपेन्डिङ अपन एक्जियल change we customize what formula to use. That's my concern.
Yes, in IOL master it automatically manipulates the formula, but in biometry, depending on the axial length, we customize the formula die.
Okay, so IL 500 मा चाहिँ जुन हामीसँग IL मास्टर 500 छ त्यसमा चाहिँ कुनको आवर रिडिङ दिन्छ सबैको रिडिङ दिन्छ कि वी क्यान कस्टमाइज दैट अल्सो
त्यसमा चाहिँ सबैको रिडिङ दिन्छ इट इज त्यो अटोमेटिकल्ली नै सेट भएको सधैँ त्यहाँ चाहिँ लेस देन 22 मिलिमिटरको लागि यो फर्मुला ग्रेटर देन 26 को लागि यो फर्मुला भनेर अटोमेटिकल्ली नै त्यहाँ चाहिँ सेट भएको हुन्छ
okay thank you for the answer. Now my next concern is हामी सबैलाई बायोमेट्री गर्दाखेरि चाहिँ जस्तो 6/60 4/60 भिजुअल भएको मोडरेट क्याटरेक्ट डेन्स क्याटरेक्ट भएकोलाई चाहिँ बायोमेट्री गर्दाखेरि खासै प्रब्लम पर्दैन तर जब when the patient has very dense cataract and visual acuity like HM visual acuity भएको PL visual acuity भएको पनि पेशेन्टहरु आउँछ नि क्याटरेक्ट गर्नको लागि
yes right.
Oh, so यस्तो पेशेन्टमा चाहिँ what can you share the tips to among the students that what are the things to be considered while doing keratometry and axial length or biometry or IL power calculation in these subjects we have very reduced visual acuity कसरी गर्ने के tips हुन सक्छ त स्टुडेन्ट को लागि
So if a patient has unilateral cataract, then while performing the manual keratometry, the patient is asked to fix it on the target near to the next eye, and we can take the key reading of that eye, and since the automated keratometry is not possible in the case of PL positive and or HM movement cases, so it is better to perform the biometry of both eyes and compare the reading.
So अनि हैन my concern is जस्तो keratometry reading गर्दाखेरि जुन मायर आउँछ नि कर्नियाबाट so is that मायर correct not is that value correct or not भनेर चाहिँ कसरी कन्फर्म गर्ने राइट र लेफ्ट को सिमेट्री कम्पेरिजन गरेर गर्ने कि anything that we can
राइट र लेफ्ट को चाहिँ सिमेट्रिक गरेर गर्यो भने चाहिँ एक्युरेसी बढी आउँछ भनेर भनेको छ भाइ So it is better to take both the key readings of both the eye and also the IOL power of both the eyes.
So अब यो भयो keratometry. What about axial length measurement? जस्तो visual दुईटै आँखाको PL HM भिजन छ क्याटरेक्ट गर्ने भनेर आयो भनेदेखि त पेशेन्टलाई टाढा हेर्नु भनेर भन्न त खासै पोसिबल हुँदैन नि त सो त्यस्तो बेला चाहिँ एकदम इरर आउने axial length measurement इरर आउने भन्ने हुन सक्छ so what are the tips to reduce perform a biometry accurately?
So we can if manual keratometry is not possible in that case, then we can take key readings from the topography and then after that we can perform the biometries.
हैन axial length measurement गर्दाखेरि चाहिँ what are the tips कि जस्तो wrong नआओस् भन्ने हिसाबले
दुबईमा PL पोजिटिभ छ भने चाहिँ त्यस्तो केसमा
हजुर हजुर
Okay, so if the patient has PL positive, then the patient is asked not to move his or her eyes and just to fix it in one position. And the examiner should also be careful that the biometry is performed in a correct way. यसरी चाहिँ हामीले चाहिँ इररहरु चाहिँ अलिकति कम गर्न सक्छौं.
Okay.
But excellent measurement is possible in that case. If a patient has PL positive also, then excellent measurement is not a big issue there. We can perform excellent as well in that case. But the most concern is that we need to be very careful while performing the procedure.
त्यही त मेनली इरर कस्तो आउँछ कि फिक्सेसन प्रपर नभएपछि त अब प्युपिलको पनि डिफरेन्ट पोइन्टमा चाहिँ पोइन्टर राख्दाखेरि त एक्जियल लेन्थको डिफरेन्सहरु बढी आउने भयो त्यसले गर्दाखेरि चाहिँ इररहरु आउने ओर्ने भन्ने हुन्छ कि रेजिडुअल रिफ्र्याक्टिभ इररहरुको अमाउन्ट बढी हुने भएको भएर चाहिँ
and we also need to take the average of at least 3 while performing biometry at तीन चोटी जस्तो लिएको छ भने त्यो तीन चोटीकोलाई एभरेज गरेर रिडिङ लियो भने चाहिँ एक्युरेसी र प्रिसिजनमा अलिकति बढी आउने भएको हुन्छ दाइ.
So this helps in minimizing the errors during biometry.
Yes, right.
Okay. No, thank you.
Thank you, Dai. So any other question?
दिदी त्यहाँ च्याट बक्समा एउटा दुईटा क्वेसन छ त्यो एन्सर गरिदिनु होला
Okay, Bipin. Manoj Mahat, picky with the extra capsular cataract extraction. Manoj Mahat, let's say PK with extra capsular cataract extraction at same time, or PK with IOL implantation after around 6 months. Which method do you prefer and its significance to biometric parameters? So PK with IOL implantation after around 6 months, it is usually according to the 2S rule. After PK, it is it is necessary that we need to see the K reading. We need to monitor the K reading, and we can only perform the IOL implantation after 1 month or 2 months, because the K reading need to be stabilized so that the accurate IOL power can be calculated. Any consideration in vitreous hemorrhage cases? So in vitreous hemorrhage case, any consideration in vitreous hemorrhage cases? So while performing the pars plana vitrectomy, we need to take the IOL measurement before performing the cataract surgery, because after when we perform biometry, after the eye is filled with the silicone oil or gas like tablet or air, then what happens is that the ion, the time taken by the sound to travel will become longer, and so the wavelength will be long, and exit length comes to be shorter. So in that case, 3 to 4 year will be obtained while performing the IOL power calculation. So IOL power calculation while performing so performed before silicone oil implantation. How do we calculate the IOL power for multifocal? For multifocal IOL, for multifocal IOL power calculation also depends on like the axial length. We need to take consideration of the axial length measurement, but it's similar to the other cases and right choice of the formula.
तर एउटा माइ कन्सर्न इज मल्टिफोकल गर्दाखेरि चाहिँ डिस्टेन्सकै गरी नै बायोमेट्री गर्छ होइन अनि आई गेस देयर इज डिफरेन्ट अनलाइनमा इन्टरनेटमा फर्मुला क्यालकुलेटरहरू मिल्छ कि अनि त्यसपछि चाहिँ अन द बेसिस अफ एक्जियल लेन्थ त्यसपछि केराटोमेट्री भ्यालु
फरक पर्ने हुन्छ, जस्तै कि के अरे नियर सेन्ट्रिक र डिस्टेन्स कन्सेन्ट्रिक भनेर हुन्छ, त्यसमा चाहिँ एनुलस रिङ भनेर पनि हुन्छ, त्यसमा चाहिँ सुरुमा नै अलरेडी इट इज डिजाइन्ड. सो आई थिङ्क the right choice of the formula can be done by calculating IOL power for the multifocal, or then you can share some of your ideas as well.
होइन अहिले चाहिँ कस्तो छ भन्देखि मोस्ट अफ द मल्टिफोकल कन्ट्याक्ट लेन्स आर एस्फेरिक युज गर्छ हुन त हाम्रो सेन्टरमा खासै युज गर्दैन होइन तर मोस्ट अफ द नेपालमा त भन्दा नि टिआईमा चाहिँ गर्छ कि मल्टिफोकल्स कन्ट्याक्ट लेन्सहरू चाहिँ जेनरली एस्फेरिक हुन्छ, त्यही भएर त्यो एनुलस रिङहरू त्योहरू चाहिँ खासै हुँदैन. एउटा यो अनलाइन क्यालकुलेटर हुन्छ कि डिस्टेन्स बायोमेट्री गरिसकेपछि डिस्टेन्स बायोमेट्रीको भ्यालु राखेपछि पेसेन्टको प्यारामिटर्स अनुसार चाहिँ त्यसले नियर एड कति राख्ने भनेर क्यालकुलेट गर्छ अनि विल इस्टिमेट अब त्यो कम्पनीले क्यालकुलेटर दिएको हुन्छ अन द बेसिस अफ द्याट विल इस्टिमेट द नियर पावर कति आयोल हाल्ने भनेर चाहिँ विल इस्टिमेट अकर्डिङ टु द्याट के त्यसमा.
हजुर दाइ, यसको बारेमा मलाई अलिक बढी धेरै आइडिया भएन. So thank you so much. And what changes in formula is done if there is silicon oil in AC? What changes in formula is done if Ayush, silicon oil भित्रसम्म राख्ने हो अनि फर्मुला चेन्ज भन्दा पनि सिलिकन ओइल राख्यो भने चाहिँ त्यहाँ चाहिँ 3 डायरेक्टर इरर चेन्जेस आउँछ भनेर भन्छ अनि त्यही भएर आफ्टर अनि सम्म चाहिँ सिलिकन ओइल च्याम्बरमा नै पर्ने छ and after that, after 1 month, it is necessary that it should be taken out because there's emulsification हुने चान्स बढी हुन्छ त्यो एसीमा गएर चाहिँ एसीमा जान सक्ने चान्स छ ग्लोकोमा हुने चान्स बढी हुन्छ so it is necessary that after 1 month it should be taken out and then the say about formula changes are but it is necessary that the operations should be done before the implantation of oil. Both eyes are undergoing vitrectomy and filled with silicone oil and while doing biometry, if we can't get the readings and what we suggested, and while doing biometry, what we use in that if both eyes are undergoing vitrectomy and filled with silicone oil while doing biometry, we can't get the readings. महत दुवै आँखामा एकैचोटि सिलिकन ओइल राख्दैनौँ हामीले पहिला एउटा आँखामा राख्ने त्यस पछाडि मात्रै आफ्टर क्याल्कुलेसन फर्स्ट अफ अल वी नीड टु क्याल्कुलेट द IOL power before the silicone oil implantation in one eye, then only after that after performing the surgery then only we will perform vitrectomy in another eye. So it depends on the cases and the formula chosen will also depend on what type of error or the vision the patient is having. So
hello
sir.
Hello. Yeah, I'm just wondering that this is not my questions, but I'm just wondering that because you have so much of knowledge and experience in this topic, are you doing
Yes,
any
sir.
sort of the studies on IOL calculations, something like in this topic, like kind of like an agreement between the two different methods, techniques, or instruments, something like that? Are you doing any studies on IOL power calculations?
Yes, sir. One of our fourth year student have also done that, but before she had selected that topic, I had been performing that before the after installation, before and after installation of the tropicamide, the AC parameter changes and also the aberration changes and its effect in the IOL power calculation.
So with tropicamide use.
Yes,
so that means the dilatation changes
yes,
the IOL power.
Yes, sir.
Pupil
It is found that
changes the IOL
slightly
power, that means.
hyperpixis.
And
yes, sir.
so what could be the reason for this, in your opinion?
After tropicamide installation, it is in most of the cases hyperpixia have been noted, and also the aberration changes. I don't know about the aberration changes, but I wanted to know what sort of aberration changes will happen. So I have been taking some cases and.
So I think that after pupil dilation, there might be some changes in the maybe in the spherical kind of aberrations. Because optically the trophic
Yes,
camera
sir.
does not change any of the optical components, I guess. So except some sort of accommodation and pupil dilatations.
Yes, sir.
It might not cause a major problem in the
Yes, sir.
aberration. So my guess is that. But I'm just wondering that if you're doing any comparison between any techniques, any instruments, that might be worth to look at. And like if
Sir,
you, yeah, one more thing, if you have some sort of mechanisms that when you did IOL calculations and patient went to the post-operation, and if there is a good record keeping of post-operative refractive care, that I think also helps you understand what things are going on in practice. So I think that will also um, um, uh, I mean that also raise your a kind of experience that also helps in your practice, I guess. So that might be a way normally how we practice and learn things. So if that sort of mechanism is there, I think that would be very good to you.
surely, sir, I will keep
Yeah.
that in mind.
Okay. Apart from that, I have nothing, none of the questions. This is just my curiosity only. Okay.
So
Thank
thank you
you.
so much for your questions,
Okay.
sir. Can you please say it? So, can you please say about apparent axial length and true axial length during biometry? Um, So usually we have the mode for the cataractous eye, and the velocity of the sound in the cataractous eye is 1550 meter per second, and it is set with that velocity. So we need to calculate the true axial length because the apparent axial length if we use the apparent axial length, then it can give the false reading. So in order to calculate the true axial length, like it has different formula for different cases, in the case of silicon filled eyes, the true axial length is calculated by the formula of 0.72 into the true axial length equals to 0.78 into the true axial length, in which 0.78 is calculated by 1133. That is the velocity of the sound in the phakic silicon oil, and 1550 is the velocity of the sound in cataractous eyes. That is while performing biometry, we always said that in cataractous mode, which has a velocity of 1550. So dividing 1133 divided by 1550, we are able to calculate the true axial length. Similarly, in many other cases, like in the secondary exchange, secondary IOL implant also, we need to we can find the true axial length by knowing the characteristic of the IOL, according to the company, the velocity, how much velocity of velocity of the particular IOL, uh, and also we need to know the lens thickness, and it is very important while calculating the true axial length in case of the secondary IOL implantation. So for different cases, different factor and different velocity of the, according to different velocity of the sound, we can calculate the true axial length. So it is necessary that we need to know some of the characteristics and also the methods methods and the mode of the biometry. So any other questions? Hello?
I think
Hello?
we have done with our queries.
Bipin,
Now,
do you have some questions?
no, I have done with my questions.
So thank you so much. So despite lockdown, I think all of our optometry students are benefited through these webinar sessions. I hope all of you are doing well. And I also want to say stay safe, stay careful, stay home. Thank you. Bipin,
हजुर दिदी हजुर
भयो सक्यो होला हैन अब
सक्यो
के सोध्नु छ भने सोध
होइन ठिक छ राम्रो थियो दिदी
हेलो गौरी सर हेलो
Hello.
हेलो
Yeah, I'm online.
Sir, I have also performing some study on BEP, sir.
BEP.
Yes, sir. I can send you the proposal, sir. Can you have a view on it?
Okay, no worries. I can do that. So you have you started study or you're just planning to do?
So I'm performing on the changes of the BEP parameters in global developmental delay, and next was one my final year thesis was the correlation of pattern BEP in strabismic and anisometropic life. So I think I will send you my project work to have a review on it.
Yeah, okay, no worries. But you need to give a little bit of time for me to look into that.
Okay, sir.
Okay. So you can send me. So which one you want to send me? Your project or the current paper?
So my final year project, I want to send you that.
Okay, so I will look at that first then.
Okay, sir.
Okay. Sounds that topic is interesting.
So which one, sir?
That VAP parameters in strabismic and non-strabismic amblyopia.
Yes, sir. But
it sounds interesting.
So I collected around 30 participants in my project, but during when I started working in BPKSS, and I also collected more patients, I increased my sample size up to around 40, sir. So is it necessary that we need to take the normal? So is it necessary that we need to take the normal patient as well?
If you take the strabismic and non-strabismic amblyopia, I think that must be enough because you're comparing the VAP in strabismic and non-strabismic amblyopes. So I think that must be fine. So that may not be a sort of like I did the last Saturday, I did a presentation on research design.
Yes, sir.
That may not be the like sort of kind of so, but it still looks like a cross-sectional study. I think that would be fine. The sample size is also it's 40 cases is not bad actually, because amblyopia is a bit the prevalence rate is low. So being that the 40 case is not a small sample, in fact. So the number is
Yes, sir.
good enough. Yeah, so number is good. The only thing is that yeah, how we can present the data. So if you have raw
Yes,
data,
sir.
in case if we need further analysis, in that case, that might be interesting to see actually. So if you have
Sir,
data, raw
and
data, that would, yeah. But before that, if you just send me that the maybe the small portion of the research, the information about the research method you are using and the result only, that would be enough at this point.
okay, sir.
Just
Sir,
result
and
and the
next,
method. Yeah.
sir, and next study also I have been performing about the multifocal ERG in hydrochloroquine toxicity patients, sir. I have collected
I
15
so
samples.
hydrochloroquine toxicity means it's the patient going in malaria treatment.
Yes, sir. No, no,
Malaria.
no, no, sir. No, sir, no, sir. SLE or arthritis.
Okay, like this. You can still present this as a case series. This sounds also interesting. This is also because you're doing multiple ERG, right?
Yes, sir.
Okay, then it
I
must
have
be interesting to see.
I have collected around 15 samples, and also I have entered in SPSS, but still analysis is left, sir. But I will be doing it
Uh,
soon.
yeah. So the sample size also looks quite. Um, it's okay. Sample size also looks it's okay actually. 15 sample size
Yes,
in
sir.
that case
And
you can present. Yeah, you can present as a pilot study outcome of the pilot
yes, sir.
study. So you can present it as a pilot study.
Yes, sir. And so I have also viewed some of the articles, and there had also been performed not much than 15 samples, or 12, 10, or like
Yeah,
only
that's why
11
I tell you.
samples.